Why does a condition that is rare in term infants remain so common and so devastating in preterm babies? Hi everyone. Today I will discuss germinal matrix hemorrhage and intraventricular hemorrhage. That is one of the most and feared neurological complications of prematurity. This topic is high yield for MBBS exams, for neonatal ICU practice, and for understanding long-term neurodevelopmental outcomes. Let's start with the basics. Intraventricular hemorrhage refers to bleeding into the ventricular system of the brain. It occurs predominantly in preterm neonates, especially very low birth weight infants. Why is IVH important? It is a major cause of neonatal mortality. It contributes significantly to long-term morbidity in the form of cerebral palsy, developmental delay, and cognitive impairment. The key reason IVH is common in preterm infants is the immaturity of cerebral blood vessels and poor autoregulation of cerebral blood flow. So understanding these conditions helps us not only diagnose but more importantly prevent it. From an exam and clinical perspective, IVH is the most common CNS complication of preterm birth. It is strongly associated with the germinal matrix. IVH is often precipitated by birth asphyxia, blood pressure fluctuations, and respiratory distress. Key concept here is that IVH is not a random bleed. It is a developmental and hemodynamic problem. Now, we must understand the germinal matrix because IVH begins here. The germinal matrix is a highly cellular and highly vascular region. It is located in the subependymal area near the lateral ventricles. It is prominent during fetal life but gradually involutes with increasing gestational age and usually disappears by 32 to 34 weeks. This explains why term infants rarely develop IVH. The germinal matrix is not just a weak area, it is vital developmental structure. It produces neuronal precursor cells and glial cells. It supplies cells that migrate to form cerebral cortex and white matter. Therefore, injury here does not only cause bleeding, it disrupts brain development itself. This is why IVH has long-term consequences even if the baby survives. In preterm infants, especially less than 32 weeks, the germinal matrix is still active and extremely fragile. Its blood vessels are thin-walled, poorly supported, and lacking mature structural elements. This makes preterm infants uniquely vulnerable to hemorrhage. Germinal matrix hemorrhage and IVH are very common in preterm neonates. They lead to acute complications like ventricular dilatation, hydrocephalus, and chronic complications in the form of cerebral palsy, developmental delay, learning and behavior problems. For neonatologists, IVH is not just an imaging diagnosis, it is a lifelong disability risk. This slide explains the core pathophysiology. The germinal matrix vessels are densely packed and lack adequate collagen and structural stability. So what happens? Even minor pressure changes can cause rupture of these blood vessels. Additionally, preterm infants have immature cerebral autoregulation. Cerebral blood flow is pressure dependent, so any fluctuation in blood pressure can translate directly into brain injury. Epidemiologically, in newborns weighing less than 1500 gram, incidence is 18 to 25%. However, there is much higher risk in newborn weighing less than 750 gram. IVH is rare in term infants. So where does the bleeding start? Most hemorrhages originate in the germinal matrix as I have explained earlier, and from there blood breaks through the ependyma, enters the ventricular system. Hence, germinal matrix hemorrhage often progresses to intraventricular hemorrhage. Let's connect theory to clinical practice. Events that trigger bleeding include hypotension, rapid volume expansion, aggressive resuscitation, mechanical ventilation, hypoxia, and hypercapnia. These events cause sudden cerebral blood flow changes, leading to vessel rupture. In approximately 80% of cases, hemorrhage extends into the ventricles due to rupture of subependymal vessels, and this defines true IVH. Neurological damage is not only due to blood. Consequences include disruption of neuronal migration and abnormal cortical and white matter development. In severe cases, periventricular hemorrhagic infarction dramatically worsens the prognosis, and it is a key determinant of long-term disability. Post-hemorrhagic hydrocephalus is seen mainly in grade 3 and grade 4 IVH. Causes include obstruction of CSF flow and impaired CSF absorption. Clinically, neonate presents with progressive head enlargement, raised intracranial pressure, and may require ventricular shunting. Periventricular leukomalacia is ischemic injury to periventricular white matter and is often associated with IVH. It is strongly linked to spastic diplegia and long-term motor disability. Remember, IVH along with periventricular leukomalacia is associated with poor neurological outcome. Major risk factors for intraventricular hemorrhage include prematurity, low birth weight, respiratory distress syndrome, hypoxia, acidosis, and mechanical ventilation. Even routine NICU procedures matter. Risk-increasing interventions in NICU are vigorous suctioning, intubation, rapid fluid boluses, and excessive handling. This is why gentle neonatal care is critical. IVH can be silent or catastrophic. Signs may include bulging fontanelle, sudden anemia, apnea and bradycardia, metabolic acidosis, seizures, altered tone or consciousness. In severe cases, coma and decerebrate posturing can occur. Because signs are non-specific, neuroimaging is essential. This slide explains the IVH grading system. In grade 1, hemorrhage is confined to germinal matrix. But in grade 2, there is intraventricular hemorrhage, but there is no ventricular dilatation. In grade 3, IVH is associated with ventricular dilation, and in grade 4, parenchymal involvement occurs. So remember, higher grade carries worse prognosis. Cranial ultrasound is bedside, safe, and cost-effective. It is usually done between day 1 to day 7 of life and is repeated serially to monitor the progression. CT scan can also be done, but preferred choice of investigation is cranial ultrasound. CSF may show increased RBCs and elevated proteins. However, it is difficult to differentiate from traumatic TAP, hence not diagnostic alone. Prevention starts before birth. Key strategies are: number 1, prevent premature delivery; number 2, cesarean section in selected cases; and number 3, use of antenatal steroids, as it reduces the incidence and also reduces the severity of IVH and is one of the most effective interventions in neonatology. Regarding postnatal prevention, focus on stability. Avoid hypoxia, avoid BP fluctuations, avoid rapid volume expansions, correct acidosis and coagulopathy, and gentle ventilation. Maintain mid-light head positioning as it improves jugular venous drainage and reduces cerebral venous congestion. There is no definitive cure for IVH. Management is supportive. Maintain stable hemodynamics, optimize oxygenation, serial neuroimaging, and early detection of hydrocephalus. Mortality increases with increasing grade of intraventricular hemorrhage, and highest mortality in neonates weighing less than 750 grams and with grade 3 to grade 4 intraventricular hemorrhage. Regarding long-term neurological sequelae, outcome depends mainly on parenchymal injury. In mild IVH, there is slightly increased risk, and in severe IVH, it is up to 50%, with major disability seen in periventricular hemorrhagic infarct. Mortality risk is 59% as compared to 8% in grade 3 alone. IVH remains a major complication of prematurity. It reflects developmental vulnerability and hemodynamic instability. Prevention is far more effective than treatment. Gentle care, anti-steroids, and early detections are critical. As future clinicians, your goal is not just survival, but survival with an intact brain. That concludes this lecture on intraventricular hemorrhage. If you find it helpful, please like the video, share it with others who may benefit, and subscribe to the channel for more educational content. Thank you for watching.